Moving right along, our next presenter is Dr. Amanda Wieland. She is a specialist in gastroenterology and transplant hepatology and co-director of the Fatty Liver Clinic and associate professor here at CU Anschutz. So she is going to be presenting on a topic that we frequently see in our setting, which is hepatic encephalopathy. So please help me welcome Dr. Wieland to the stage.
Thank you. Hello, I want to thank the organizers for inviting me to come today. This is a nice opportunity for me to kind of meet a different audience than I get to work with on my day-to-day basis. I know you guys are out there in the trenches doing some amazing work. All right, we'll see if I can operate the technology. I will admit my bias is that in my practice, I'm chronic liver disease. I see kind of the whole spectrum of liver disease, cirrhosis, and then we do a lot of transplants. So I mentioned a little bit of that in here. I recognize that's probably not on the radar for a lot of the patients you guys are caring for, but that's a little bit my bias, as I'm always thinking that. So I've been tasked today with talking to you guys about hepatic encephalopathy, and I'm going to try to focus about issues that come up for you guys in the long-term care setting. All right, so goals today. One of the things is I wanted to talk about just the overview, the definition and classification of all these different terms we use to talk about hepatic encephalopathy. And then I'm going to highlight a little bit of the pathogenesis, mainly so we could think about why the different tools work in looking at what's driving hepatic encephalopathy in our chronic liver disease patients. And then we'll focus a lot and try to actually come up with some practical things about how to treat overt encephalopathy in the long-term care setting. All right, so hepatic encephalopathy. One thing to know, it is a clinical diagnosis. This is something that you guys from a clinical standpoint will be able to diagnose this, and I think you guys kind of know it when you see it most of the time. The main Liver Society guidelines from 2014 define it as brain dysfunction caused by two different things: liver insufficiency and or portosystemic shunting. So both of those contribute in our patients with chronic liver disease. It can manifest in a wide spectrum of neurologic psychiatric abnormalities, subclinical, all the way through coma in some individuals. So let's talk a little more about that. So hepatic encephalopathy, so again, two main things driving it. Primary liver dysfunction, so this is at the cellular level, that the liver is important to actually have the blood get to the liver, coming from the gut, and then actually detoxify, remove the bad humors per se. The blood also has to get to the liver. So the gut is where all of our portal blood, we're absorbing our nutrition, all those things. It all filters down into that big vein, the portal vein, feeds into the liver. And so it's got to get there, and then the liver has to be able to cleanse it. So you actually do not need liver disease to have hepatic encephalopathy. Caveat is that you guys are going to be seeing it in patients with chronic liver disease, but there are rare cases where it's actually the systemic shunting, where the blood just skips the liver from an issue of the plumbing. You can see there, I don't know if you guys kind of remember back to this, there's actually several different things that can lead to portal hypertension and then shunting around the liver. Intrinsically, the most common cause is cirrhosis. So that is what it's going to be. And again, we're not aiming for all the zebras here, but just kind of thinking about, you don't want to miss things, but it's usually going to be cirrhosis. The other things that we think of, there's, those post-hepatic, so heart failure and other things that might prevent the blood from getting out of the liver that'll push back on everything. Again, intrinsic. One thing to think about are these the shunts that are pre-hepatic. So you guys probably have taken care of patients that have portal vein clots for some reason, either hypercoagulable or liver disease. We can get a clot there. And in that situation, you'll actually just divert that blood because it can't get there around the liver. So there are these rare cases of these portosystemic shunts that are actually congenital. So that's kind of a weird and wacky way. But again, not going to be what you guys see, but those are some things just to think about. All right, so a little bit on the pathophysiology. And again, this is just so we can kind of understand why our tools work. There's lots of different players in HE. Liver, obviously very important. The gut microbiome, though, is very important. Patients with liver disease have a very dysfunctional gut, dysbiosis, all of those things, and again, the shunting. One thing that's going to be a highlight and a tip for you guys is that this is not just about ammonia. I recognize it is the biggest one in the middle there, saying ammonia, but actually ammonia is not the only driver of this and is actually not helpful to check ammonia levels in this situation. So let's talk about a little bit this, just defining acute liver failure versus chronic liver disease and how hepatic encephalopathy is different in these two entities. So acute liver failure, hopefully you guys are not seeing acute liver failure very often, because that is something that is a very different entity. So acute liver failure is going to be somebody that does not have underlying chronic liver disease and has some sudden severe injury of the liver. We think of Tylenol. Obviously, a Tylenol overdose will just shut the liver down. Certain other medications and other things, you might have more of a subacute. This is something where within like a few days or weeks, there's a severe injury and the liver just starts to shut down. And so in that setting, it's a very different mechanism. So the ammonia actually does drive things in this, and the blood-brain barrier is not ready to handle this load. The ammonia crosses the blood-brain barrier, and the astrocytes actually swell. So there's swelling of the brain, you get cerebral edema, and then herniation. So the dreaded complication with acute liver failure is going to be actually herniating the brain. And that's what patients actually die from in acute liver failure. So when we have somebody coming in with a Tylenol overdose and they're showing up with new coagulopathy, new encephalopathy, that's what we're watching for. So they go to an ICU setting, we're doing dialysis, we're doing all these things to regulate this blood-brain barrier and these acute ammonia levels. Chronic liver disease, and that's what we're talking about today. That's what you guys are seeing on a regular basis. That is very, very different. Having chronic liver disease actually protects you against this acute issue of that flux into the brain. There's this osmotic buffer that happens, and so they do not get cerebral edema. They do not get herniation. So it's just a very, very different entity. And that's why it's a very different kind of focus of treatment. So again, hopefully you guys aren't seeing acute liver failure on a regular basis. The other thing to think about in just pathophysiology is how much the gut contributes. And so with this portal hypertension, so you see all that gut there. You've got your bowel, small intestine, large intestine. Basically everything's backed up from nothing draining well from our scarred, sad liver. And that impairs a lot of things. So one, nothing moves well. So you get gut dysbiosis, you get bacterial overgrowth, and then you also get this leaky barrier. And it's all kinds of things leak across that barrier. It's going to be ammonia, but it's endotoxin, it's actual bacteria, all of these things. So lots of different players. It's not just the ammonia levels. And this is just kind of highlighting that it's across this whole spectrum of all these different pathways that are going to contribute to the encephalopathy. Now, we always love to classify things and have new systems and gradings and all these. So we're the same in encephalopathy. So a few different classifications. So type A is the acute liver failure. So that we already talked about, that's sudden onset, not chronic liver disease, very different management. It's in an ICU, all of those things. Hopefully you guys are not seeing that. Type B is where someone just has this portosystemic shunting. So this, again, the liver is working fine, the blood just doesn't get there. The third type is going to be with cirrhosis, where you're going to be seeing both mechanisms of shunting and the intrinsic liver dysfunction. It's both the liver not being able to clear things, and there's the shunting where the blood won't get around. Those both contribute. So these classifications, there's a few different terms out there. So there's the grading of encephalopathy. It goes away from minimal and then grade 1, 2, 3, 4. And then it gets bulked into covert versus overt. So covert is going to be minimal in stage 1. So this is subclinical. This is where you actually have to have specialized testing to even detect that something's going on. And so this is something that is not going to be what you guys are going to be titrating for. This is something where, sometimes I see patients in clinic that might have underlying liver disease, and getting this dedicated testing for certain jobs, an airline pilot that has, concern for liver disease. So some of this is relevant in a very different setting, and no, it does exist, and there's certain times you might titrate for that. But it's going to be more the overt that's going to be what you guys are having to deal with and really triage and use medications for. So overt is going to be your stage 2, 3, 4. And this is diagnosed clinically. So really, this is using a mental status assessment. These are the patients there, if you look, that are having, asterixis. So you check them and they've got the flap. So this is something where you don't need other blood work. You just know they have underlying chronic liver disease, cirrhosis, they're at risk for this, and they develop these symptoms that are consistent. Recurrent overt is when you're having greater than 2 bouts within 6 months, and then there's also this terminology for persistent. This is where they just really don't get back to their baseline between these bouts. So these are kind of the big buckets of terminology that we use. So we've got our different types, the A, B, C. Again, we're focusing on the C, this chronic liver disease. You've got the grades, and kind of bulking them into the covert and the overt is probably the most practical way to go about it. And then these different kind of episodic, recurrent, and persistent. And then we'll talk more about always looking for precipitants, because in general, most people have something, they're at their baseline and something tips them over with chronic liver disease versus that they just have an episode happen. There are patients that have very brittle encephalopathy and they just will have these spontaneous bouts, but often there is some kind of trigger that you identify, and looking for those and reversing that trigger is very important in the management. So this, again, we're going to be dealing with the overt encephalopathy, and these are going to be individuals that just have kind of early disorientation all the way through coma. You don't need these fancy tests to be done to diagnose this. It's a clinical diagnosis, and in general, these will have some of that early asterixis is one of the key exam findings that can be helpful. All right, so let's talk about ammonia. That's always a big question that we get. So what is the role for ammonia levels to help as a tool? They really are not useful in hepatic encephalopathy management with chronic known liver disease. They're unreliable for the diagnosis. They can be elevated when there's no symptoms, and so titrating medications to treat just a number is not the right thing for these patients. So you do not want to titrate just based on that level. They're very poorly correlated with actual symptoms and degree of encephalopathy, and so they are not necessary in the diagnosis. The one time that they are kind of used is actually the initial diagnosis of some altered mental status, or, so sometimes there's a scenario, but you always want to think about, why am I doing this? Is it, I'm not sure what the cause is, and I don't see that having a role for you guys. So really, these are something that you don't need to be checking. And here you can see, this is something where it shows, you can see grade 0, the ammonia levels went all the way above 100. So somebody completely asymptomatic and they have abnormal ammonia levels, but they have no symptoms. You don't need to titrate for that. And then all the way up to grade 4 where they're in a coma and they have normal levels. So it just isn't a helpful test. So you don't need to bother. And they're hard to get too. You gotta put them on ice, and so don't need to do that. So then let's talk about the management. All right, so we've got our clinical diagnosis. You have a high suspicion that you have a patient with chronic liver disease and they've got a change in their cognition or mental status. So the first thing is making sure that it is consistent, using your clinical diagnosis, and make sure there's not another cause. And this is actually very challenging for you guys. And I wish I had better tools other than kind of knowing your patient, knowing their baseline, and knowing they have underlying liver disease. But there are other things that could be going on. So this is kind of just a general list of things to think about. I know you guys know all this. If they're diabetic, make sure their blood sugars are checked. I'm hoping they're not just intoxicated. But that probably does happen, actually. So, and other toxins, new medications, all of these things are think about. As far as you need to do a brain scan on everybody, if there's not any history of a fall or something, then it's probably not as necessary if there's not focal changes. But, a good history and all those things, I think if something changed, that this is now acutely happening, to make sure that there's nothing else going on. And then you always want to think about, again, these precipitants. There's usually something that somebody, if they're on a regimen and they're doing fine and there's a change, often there's a trigger. The big things we always think of, could they have bleeding? That's going to be more common in a cirrhotic patient. Electrolyte abnormalities from their diuretics. Are they on a new medicine? Are they dehydrated? And always infection. Infection in cirrhotic patients. They're relatively immunocompromised, so they're high risk for infections. So it's something to always think about. Ideally, you'd be able to kind of suss out symptoms, but it can be hard when they're confused. So trying to think broadly and kind of knowing what they're at risk for. And you can see here, kind of just highlighting those different precipitating things to think about. And then you want to initiate therapy. So once you feel confident that this is worsening of their encephalopathy, you've made sure there's not any other precipitants going on, then you would think about, how do I treat them? How am I going to improve these symptoms? And so we'll go through these all in detail, but lactulose is the main thing. That's the cornerstone of all treatment. And then one thing to know about is a tip is that Miralax can work just as well. We'll talk about that. And then rifaximin is also a nice tool, and then we'll talk about nutrition. So, all right, lactulose. I'm sure all of your patients love it when they're on it. I have a few people that like it as a tool to poop well. So lactulose, it is our first line therapy. It's indicated to maintain somebody on after their first episode of overt HE. The true mechanism is actually not really known. It does have this theoretical change in the pH of the stool that theoretically prevents some of the absorption of the ammonia, but most of it's just it makes you poop. And actually moving in catharsis and having regular bowel movements, I mean, I always tell my patients it's good for everybody. The older we get, the more important we realize having regular poops is. So that is really the key thing, is actually maintaining a good bowel regimen in these patients. The goal in general is titrating to have at least 2, and it depends on the person. They kind of learn how much they need to poop per day. 3 to 4 soft bowel movements. There we go, happy poops. And again, you're gonna titrate it to their mental status, not the ammonia. Now you guys have the challenge of the patients are probably not gonna be, for many reasons, good about titrating their own medications. One, they're probably not allowed to. And how that can be done effectively, when I'm seeing outpatients that are on their lactulose and talking them through it, I tell them, I don't care what your dose says. I want you to take enough lactulose to poop 3 good poops per day, and that's what we're aiming for. And so that's really the goal there. It's that response. It's not like a blood pressure medicine you gotta titrate. We're just looking to have good poops. The things you need to watch out for, obviously you don't want them to poop too much. And this is a problem in somebody that may not have the ability to know to kind of adjust their own dose, and kind of how to do that is a challenge. Having good staff that know, and even inpatient, honestly, when we have somebody come in inpatient on our service, a cirrhotic, if they're on a liver floor, and we're lucky enough to have our transplant floor, our advanced liver disease, our nurses are amazing, and they know how to do this. Some of the other floors who are amazing at like pulmonary things may not realize that even though the patient says they don't want it, they need to take their lactulose, and we got to titrate it and really pay attention. So you got to watch all that. Well intended though, if somebody has too much poops, they can get dehydrated, and then you can be chasing your tail. We have patients that get a NG tube placed, you're aggressively making them poop in the hospital, and they'll actually get hypernatremic, which is not normal in a cirrhotic patient, and it's because of all that free water loss. So you have to just be careful with watching the electrolytes in these patients. Common side effects. I say diarrhea in quotes because it is a soft, watery, kind of more urgency type poop for a lot of people, and it's unfortunate, but they have to just get kind of used to how it can work for them. And so it's kind of talking them through that you need to have like a good size soft bowel movement. It does cause a lot of bloating in some individuals though, and gas and nausea. And so that can be a big barrier that they just really can't take it. And this is where Miralax can actually be quite effective. If the goal is just to get them pooping regularly, I find that to be a very good tool. It also helps with compliance because the taste of lactulose, it's very, very sweet. Well, I did have one patient that liked putting it on his waffles. That doesn't work for most people. I had one person also put it in tea. They were from the South, and it was like a sweet tea type thing. So there's tricks to get people to take it regularly, but in general, some people, it's just not palatable. So Miralax, it works quite well. It was studied inpatient and shown to be just as effective when we're just doing kind of a bowel flush to get someone pooping if they're coming in. So it's something to definitely think about. It can improve compliance, and it can be very effective. In some people that, added benefit of the pH of the stool and the lactulose, it might be better for them, but it's definitely something that you can kind of titrate and figure out. All right, let's talk about rifaximin. So rifaximin is basically an antibiotic, but it's one that when you take rifaximin, as you guys know, it doesn't absorb into the systemic circulation. So its mechanism of action is within the gut. And so by acting within the gut, it addresses that issue of the gut dysbiosis and the bacterial overgrowth that's very common in cirrhotic patients. And so as you decrease the total volume of the bacteria, you then have improved symptoms. So it's recommended to add in after the second episode of HE. So if they're not able to be maintained on lactulose alone or Miralax, whatever you're choosing, and they're having their recommended amount of bowel movements, this can be a nice thing to add in. It's not typically something that would be used as monotherapy without addressing the bowel movements. Now, do I have some people that have baseline like 8 bowel movements a day from whatever chronic diarrhea they have? Then they might be on the rifaximin alone. But you don't have to titrate for bowel movements for this. So that's more just making sure they're pooping regular and have a good bowel regimen, and rifaximin acts independent of the number of bowel movements. The biggest challenge is cost. It's honestly, it's very expensive. it's kind of changed as far as kind of how access and cost coverage is. You guys probably know more about how things work where you are. Outpatient setting, it's very challenging. It used to be covered more, but then they changed a lot of the patient assistance programs, so it's always a battle to get it covered if it's not under their insurance. So that is a big barrier. It doesn't have a lot of major side effects or concerns, and most patients tolerate it very well. Okay, one important thing, I know you guys all know how important nutrition is in your patient population. Cirrhotic patients and patients in long-term care facilities very at risk for sarcopenia, malnutrition. So it's really, really important to optimize their nutrition. There's this old teaching that still sometimes lingers that you should restrict protein in these patients. You should not restrict protein. That is not linked with worsening of hepatic encephalopathy. And when patients get malnourished and sarcopenic, they're going to be at risk for worsening episodes. So in general, you want to encourage protein, well-rounded diet, and also more frequent small meals has been shown to be beneficial. And also giving a protein or complex carbohydrate-rich meal kind of late at night, like a late night snack, has also been shown to be beneficial. It helps with that overnight fasting that the cirrhotic liver is not good at fasting states. So it basically starts to just eat away at your muscles and you become very catabolic, especially at long fasting periods. So kind of having more frequent small meals and then a midnight snack can be a nice way to try to help maintain a patient. So aggressive nutrition, using nutritionists to help in your patients for that is really important. All right, there's a few other things out there. I'll tell you, most of these, there's not like robust data that they do a whole lot, but these are things that are in general felt to be safe. Those are really the main FDA things that I already went over. So things you could consider. In general, nutrition, again, very important across the board. There are a few kind of micronutrient things out there, and one of them is zinc. So zinc is part of the, it's a cofactor in the urea cycle. I don't know if you guys want to go all the way back to like high school biology and the urea cycle where you're breaking down ammonia, but you need zinc for that. So if you're zinc deficient, then that doesn't work as well. In like the randomized control trials and when they did like the meta-analysis, it didn't have a robust impact, so it kind of fell off any guidelines. But I definitely check my patients' zinc levels, and if they're low, I'm like, why don't we add in some zinc? It's pretty safe and effective. So just thinking of that and other micronutrients and those kind of things, making sure all of that's optimized. Probiotics are an interesting option as well. They do have some data where probiotics can help decrease encephalopathy episodes. I will say I can't wrap my head around how putting somebody on rifaximin and a probiotic, it seems like it's mean to the like probiotic you just gave it, you're like killing it, but that's just my own cognitive construct there. But so I think it would be used in somebody who's not on lactulose or not on rifaximin as kind of a pre-needing that, and it can help. So it's something that there's no contraindication, so probiotics are a good thing. The other interesting thing is Lola, not just a showgirl, if anybody likes Barry Manilow. That every time I see that song goes through my head. But Lola's interesting. Lola, it's L-ornithine L-aspartate. And it is so those are amino acids. And again, they feed into the urea cycle and they help at the synthetic level kind of boost up your ability to clear ammonia and the bad humors that build up. It's actually approved in other countries, and there's some prescription forms in like India and other countries, but it's not FDA approved here. And again, it's kind of like it works, but not enough to get approved here. And so it's kind of hard to get. You can get it on Amazon, but like there's not like a consistent way to prescribe it or get a reliable source. So I found it challenging to really be able to add it in effectively. I do encourage it. I offer it in some patients, and I try to find a good Amazon website, but it's a little tricky to use, but can be an option. Now, another interesting question. So, one question comes up is, what is the prognosis of these patients with chronic liver disease that are struggling with encephalopathy? One of the banes of the existence of all of this is that encephalopathy, when it happens, it kind of cascades, and it's hard to manage it unless for lots of reasons that you guys all know, and is the number one cause for readmission. Because, once somebody's already confused and more confused, trying to get them to take lactose can be very hard in that setting, and a repeat admission happens. So that is one of the things as far as prognosis. And the other thing is that hepatic encephalopathy is showing that someone has shifted from stable chronic liver disease, compensated cirrhosis, where people tend to be pretty stable with compensated cirrhosis, that it makes them decompensated. And while at least in the short term they may continue to be fairly stable if they respond to medications, it's just kind of portending that things are not going well. It's more of an issue of in the coming years, there's increased mortality. How it affects the coming months, and is this somebody that would be appropriate for hospice care, those kind of things. It's not at that level, but it's just something that in aggregate is like, it just affects those kind of quality of life and those discussion on their goals, goals of care and all those things. So it's important to consider, but it's more kind of that aggregate in the coming years. I will say, as a transplant hepatologist, if somebody, in certain contexts, once they have encephalopathy with underlying liver disease, because this is at risk for future complications, we think about liver transplant indication. So, for your population, that's not going to be necessarily kind of what the path will lead to, but just think of it in that context that it's, not necessarily hospice, but goals of care, kind of what their quality of life, it's something really important to consider. So a few quick take-home thoughts. Oh, my thing went red, I apologize. I get the thing like dragging me off the stage. So take-home points. So overt encephalopathy is a clinical diagnosis. This is something that you guys know how to diagnose this and can. Not all confusion in a cirrhotic is necessarily HE, so you want to think of all those things as you're doing. You do not need to use ammonia levels. They are not helpful and they're not good. Don't do them. Lactulose, mainstay of treatment. Compliance is hard, but good titration, good poops, cornerstone of treatment. Think about Miralax, though. It's a nice option. Once someone has HE, it does kind of switch to this. You're worried about their long-term prognosis, of course, but it's kind of more an aggregate, something you need to think about and what's best for that patient. All right. Thank you, guys.
Thank you so much, Dr. Wieland. That was amazing.